I'm Hsiao. I'm one of the nuclear medicine physicians at Royal North Shore Hospital. Thank you for the invitation. Thank you, Sydney Vital and PetNet and AstraZeneca for organizing this. So I'm just going to talk a little bit about the imaging perspectives on the current rectal cancer management. So suffice to say, imaging has come a long way. This is what we used to do, a barium study. This patient has a rectal vesicle fistula. We can see the contrast going to the bladder. We can do a lot more now. Just to echo what Alexander has presented, the neoadjuvant therapy is really good results. 5-year local recurrence rate decreased to about 6% from 11% if you just do TME alone. And we do chemo and radiation together. Seems to give a better result, downstage in 28 to 65% of the patients. I promise this is the only gross specimen slide. Don't want to ruin your appetite tonight. So according to the recent literature, 8 to 27% of patients will achieve pathological clinical response. Pathological means when they take out the specimen, it's YPT0N0. This figure is up to 42% in some of the literature on distal rectal cancer. According to Haber-Gamma and his recent literature, to achieve clinical response, you can do that in almost 30 to 70% of the patients. And that's done according to a set of clinical criteria. Often the imaging doesn't play a big role. I mean, Alexander talked about using PET and MR. However, they mainly are used to exclude extrarectal disease. So this is just a slide summarizing this. So basically for imaging person like me, it's about can we provide a role in better patient selection for these patients that will go into a wait and watch approach. Ideally, we would like to have a test that can identify patients with YPT0N0 disease after neoadjuvant chemoradiation therapy. Or there should be a very sensitive test that we can detect local recurrence once the patient enters this kind of wait and watch approach. It's also important to identify people who actually don't respond to the chemoradiation. And maybe there's a role of escalation therapy. Maybe the surgeon needs to go in earlier while there isn't a lot of radiation-induced fibrosis. So looking at the PET literature for treatment response, very complicated slide, but basically this table summarizes the variables that the people have been looking. Simply looking at the SUV value, or you can look at visual subjective assessment, or there's something called resistive index that people have come up with. It's basically the SUV max before the treatment and after treatment, the difference divided by the the pre-treatment SUV max. So it seems to be that the resistive index is the way to look at these. You achieve a better sensitivity while maintaining the specificity. They also look at whether we should do the PET-CT during the treatment or after the treatment, after neoadjuvant chemoradiation. The number suggests that we should do it during the treatment, again, achieving higher sensitivity and maintaining the specificity. So these are the selective studies that specifically looking at doing PET-CT during the chemoradiation, usually 1 to 2 weeks after commencing the treatment. And I have highlighted the one that really compared with the pathologic complete response, the PCR. The numbers suggest that the SUV max cutoff will be around 40 to 50%. So if we see a 40 to 50% drop in SUV max, that's usually a very good indicator that the patient will have a complete pathologic response. And the positive predictive value is a bit variable in these literature, some of them reporting up to 100%. But I think we need more data on how we can do it. This is just an example that we have seen. This is the pre-treatment PET-CT with the SUV max of 9.5. It dropped to 1.5 as soon as about 2 weeks after the chemoradiation. And this, according to the calculation, the response index will be 80%. And this is considered this actually was proven to be complete complete pathologic response. So what about looking at the lymph nodes? Lymph nodes are small. They can be very difficult. But there are papers out there suggesting that PET-CT can also provide a really good role in monitoring these nodes. This paper done recently suggests that there's a significant overlap when you have N1 and N2 disease. The SUV max before treatment and after treatment kind of overlap significantly. However, if you have N0 disease after chemoradiation, the SUV max doesn't seem to go beyond 1 or 0.5 in most cases. So potentially there's a threshold that we can identify that the patients are actually having complete response in their lymph nodes as well. Of course, large-scale studies will be required, and in reality, I think, just showing a case, can anyone see that lymph node there? It can be difficult. Lymph nodes are so small, and we know anywhere between 25% of the lymph nodes that are involved are less than 3 millimeter. So I think MRI shows lymph nodes better, but I think we will have to look at the data in the future to see how effective PET-CT is in restaging lymph nodes. This is another case. This is a very aggressive tumor that's actually invading into the vaginal stump. The patient had hysterectomy. The PET-CT perhaps has more role in looking at inguinal nodes, pelvic sidewall nodes, or para-aortic nodes, as they are away from the primary site. So what about MRI? So the systemic review published recently suggests that a 3T magnet should be used in restaging these patients. We achieve a higher sensitivity compared to 1.5T. What about using T2, and what about using diffusion-weighted imaging? That's getting a lot of attention in the literature. According to the paper compiled here, adding diffusion-weighted imaging, that's basically looking at the hypercellularity of the tumor. You can also achieve a higher sensitivity. So diffusion-weighted imaging should be applied in assessing treatment response in these patients. However, again, the numbers seems to be quite variable among different studies and different centers. Diffusion-weighted imaging is actually quite difficult to do. The number you generate will be different depending on the magnet you use, whether it's GE, Philips, or Siemens, and whether it's 1.5T, 3T, and also there's patient factor as well. A lot of rectal air will actually compromise the image quality of diffusion-weighted imaging. Just some of the examples. Unfortunately, this is a false negative case. So you can see that the tumor before treatment on T2 weighted imaging, after treatment, diffusion weighted imaging, before and after treatment. So this case was reported that there's a residual thickening in the posterior rectal wall, and the restricted diffusion persisted after chemoradiation. So that was called residual disease. However, when they took out the specimen, that was just fibrosis. And there were no residual disease. So fibrosis can actually cause false negative. This is a false positive case. So again, a very large semi-annular tumor before and after treatment, restricted diffusion before and after treatment. There was no restricted diffusion in this case, and the tumor significantly reduced in size. However, when they take out the specimen, there were viable cancer cells, a few of them. So this was actually classified as a false positive case. But the question is, are these cells genuinely viable? Or if we wait a bit longer, that these cells will actually die off? So nodal status is important. It's a very important predictor for disease-free and overall survival. Using MRI and conventional sequences alone, the sensitivity and specificity is mediocre, and the diffusion-weighted imaging can improve nodal staging. By this paper, sensitivity goes up to 97%. However, the positive predictive value is mediocre. But we know that if the primary tumor is responding, then the rate of residual nodal disease goes down. If we have a YPT0 tumor, by looking at all the nodes taken out, there's only 2.2% chance of finding residual nodal disease. So if we can incorporate or look at the primary tumor first on the imaging, that may give us an idea how likely the lymph nodes are responding. This paper looking at the lymph node size on MRI, and if there were no suspected nodes before or after chemoradiation, there's a 92% chance that the patient doesn't have any residual nodal disease. This is after chemoradiation, all patients after neoadjuvant chemoradiation. If the patient had previously suspected lymph nodes and they reduce in size to less than 5 millimeters in diameter, there's about 70% chance that there's no residual disease. I mean, there's still about 30% chance that there's residual. If we look at the patient with persistent lymph nodes that look suspicious, then about 60 or 70% chance that you're going to find residual nodal disease. If you have previously suspected nodes and they completely disappear, I think the number is a bit too small. They reported that 50% will be N0, but I think there's a bit of a statistical noise in there. However, if we look at the patients who are showing primary tumor response on MRI, the number improved dramatically. So if you have no suspected nodes before or after, 100% chance that there's no residual disease in the lymph nodes. And the number goes up if the lymph nodes reduce in size from 70% to 86%. So I think it's selecting a group of patients that you know the pretest likelihood of residual nodal disease is actually low, then applying MRI can achieve a better accuracy. So bear that in mind. And how important is N0 status after neoadjuvant chemotherapy? It is a very important predictor of disease-free survival. If we take out lymph nodes and they look like they were tumor before and they show complete response, these patients actually do really, really well, even compared to patients who had their nodes taken out and there were no pre-existing nodal disease. Or even compared to the black line, these are patients who had primary surgery and there were no nodal disease found at the surgery. So in fact, I think the lymph nodes showing response is actually a very important prognostic marker for these patients. And if primary tumor is responding, the nodal disease follow in the same manner. This is just an example on T2 and diffusion weather imaging before and after treatment. You can see the primary tumor significantly reduced in size. There were no residual restricted diffusion. And that lymph node on the left pelvic side wall, which showed restricted diffusion before, has disappeared on the diffusion weather imaging and has significantly reduced in size to less than 5 millimeters. In this sense, we know there's about 85% chance that this is N0 status. However, having said all that, I think at the moment the literature out there recognize the positive predictive value for PET and MRI are not yet good enough. There's a head-to-head comparison published recently. All patients underwent MRI and PET before and after chemoradiation. And these are the numbers that were published. Very mediocre sensitivity and specificity. The positive predictive value without diffusion weather imaging was only 13% in this study. For PET, it's a bit better, 26%, but those numbers are a bit depressing. So what about new things on the horizon? FLT, it's a thymidine analog that we can use to look at tumor proliferation. This potentially could be helpful because that shouldn't really increase in areas with inflammation or fibrosis. Should go to the areas with tumor proliferation. So potentially FLT may be better as a tracer to monitor treatment. However, having said that, I only searched one paper with 10 patients in there, and they concluded that FLT was not good in monitoring rectal cancer response. There are other things we can do on PET-CT other than SUV max. Metabolic tumor volume. It's a semi-automated way that we can measure the effective tumor volume. And we basically set a threshold of 40% SUV max compared to the lesion's brightest voxel. And we can look at this before and after treatment and to see if there's significant reduction in the size of the tumor. This will be more reproducible than the MRT2 volumetry study, but however, there's still lack of evidence out there. But there are many other ways we can look at the data we acquire on PET-CT. And maybe there are new super tracers that nuclear medicine department is keeping up our sleeves. The future direction of MRI, I also think is probably quite promising. We need more reliable and reproducible imaging criteria. And what about using it in combination with PET? The use of potential PET-MR in this situation. Is there incremental value between the two modalities? MR perfusion is also catching a lot of attention in the literature. This is a case that I got from the literature. So basically, K-trans is a measure of how fast gadolinium molecule can move from the vascular space into the extracellular space. So it's kind of talking about vascular density, microvascular flow, or capillary permeability. We can extract this information using the 3D dynamic contrast enhancement T1 weighted imaging. And this paper suggests that the pre-treatment, pre-chemoradiation mean K-trans, when it's high, the patient are much more likely to respond to the chemoradiation. And this example shows on T2, the tumor continued to decrease in size. That's pre-treatment 2 weeks after, and after completion of chemoradiation. The red bit is the area with high K-trans, so very leaky capillary or very high vascular flow, and that redness disappeared as the patient, as we follow the patient after chemoradiation. So that potentially tells us the biological behavior of the tumor, and that may be additional marker that we can look at for predicting the response. Other kind of future direction is we can look at the tumor heterogeneity, the presence of mucin, the presence of necrosis. These may actually give us other indication that the tumor is actually of poor prognosis. Mucinous carcinoma can occur in up to 20% of the tumor, and it has been reported in some literature that they show lower rate of response to neoadjuvant chemoradiation. This is a case from the literature. They show very high T2 signal as compared to other kind of typical adenocarcinoma that we see. In this case, you can see it's actually only part of the tumor contains mucin, so preoperative biopsy may not accurately diagnose the tumor being a mucinous tumor. In this paper, MRI detected 60 mucinous tumors, whereas a pre-op biopsy only diagnosed 15 of them, and they seem to show much higher rate of residual primary tumor and residual nodal disease compared to the non-mucinous carcinoma. So that may give us an idea who is actually more likely to respond, like the proteomics and other markers that we can use. So MRI, I think the diffusion is promising. MR perfusion may play a role in the future. It's difficult to do, but it gives us an idea of how leaky the capillary is. At the moment, there's no standardized protocol. There's no best ADC cutoff value. And as we say, the ADC value varies on different magnets, different environment, able to stage M disease. But the lack of radiation may allow us to continue to follow up these patients more closely. PET, we have a standardized protocol, but we don't have a standardized criteria for response. Maybe the resistive index that we talk about is a good way of looking at it. We know the best timing is probably during the treatment early on, before a lot of inflammation sets in. We don't know the best cutoff value for resistive index, limited spatial resolution, and there's radiation exposure. So Maestro Clinic actually has validated this model that you can put in the tumor length and the SUV max before and after the chemoradiation. And that will actually give you a number saying how likely that the patient would have complete pathologic response. So if we just put in the tumor length of 4 centimeter, SUV max before was 8.8, and now it's 2 after chemoradiation, there's 63% chance that the patient will achieve pathologic complete response. So that may be a very good start, but I think this tool will be refined in the future with various factors that we can do. So neither MR or PET at the moment can detect accurately microscopic residual disease. The accuracy can be compromised by inflammation, fibrosis, ulceration. Both PET and MR are at the moment mediocre for lymph nodes restaging. But looking at the primary response may shed some light and improve our accuracy in predicting nodal response. New imaging parameters, metabolic tumor volume, K trends, there are a whole host of things that may be coming out in the literature in the future. So I think overall, as an imaging person, the challenge lies whether we can help to identify these patients who are safe. Doesn't have to be complete metabolic response, but at least safe to undergo a wait and watch approach. Maybe the imaging doesn't play a role. At the moment, Haber-Gamma's group is showing that using a set of clinical response is doing quite well. But can we improve that even further? Can we watch them over time? How and how frequent? Maybe MRI is a more useful, has a more useful role in doing that. Can we identify patients who may benefit from minimally invasive resection if we only see a very small residual tumor and be confident about that? It's also important to identify patients with partial or no response, and so we can escalate or modify therapy, or perhaps they should go for surgery early on to really achieve that R0 resection. So is there a new paradigm? I think it's going to be an incorporation of clinical findings, biochemical finding markers, maybe genetics in the future, and then biopsy and imaging findings, and then we can put them into 3 groups: the good, the bad, and the ugly. The complete response, wait and watch, and then when they have recurrence, we can perform excision. Partial response, maybe if it's small enough, we can do minimally invasive surgery or any other surgical technique that can really achieve R0 resection. When it's poor response, can we give more radiation? Can we give other chemotherapy agents? Or shall we move on to surgery early on to really achieve that R0 resection? Just as a quick note about staging as well. So there's currently no Medicare item for staging of colorectal tumor using PET. Most studies show that it does change staging and management. However, the criticism is that the evidence is not strong enough, and also there's a high cost effectiveness. So I think we need to look at how we can select patients to improve our effectiveness in using PET-CT. We know patients with extramural vascular invasion, they have a much higher rate of metastatic disease. We know patients with pelvic sidewall or distant nodal disease, they have much higher rate of metastatic disease. So how can we incorporate that into, when we order the PET-CT, we know the strike rate is higher. This paper that I came across was quite interesting. So if we look at high-risk MR features, if they have T3 disease with extramural extent greater than 5 millimeter, or if they have T4 disease, or they have involvement of the mesorectal fascia, or they have sphincter involvement, or EMVI positive, the rate of finding a synchronous met on PET-CT is up to 30%, compared to 4% if they don't have high-risk MR features. So maybe this sheds some light on how we can select patients that really needs a PET-CT for accurate staging. And that's my talk. Thank you very much.